Hello everyone, my name is Dr. Dhara Mehta and I'll be covering your practical on reversible cell injury, which includes cell degeneration, intracellular accumulation, and calcification. Now, coming to the basic mechanism of cell injury, now there is a normal cell state called homeostasis. When exposed to stress, it leads to adaptation, but when the cell is unable to adapt, the cell will result in cell injury. Now, if the cell injury is mild and transient, then in that case, the cell injury will be reversible. And when the stressor is removed, the cell will return to its normal state. If the cell injury is severe and progressive, then that will lead to irreversible cell injury that can be necrosis or apoptosis, both of which lead to cell death. Now, reversible cell injury results from non-lethal injury, that leads to less than actual death of cells. The causes of non-lethal injuries are hypoxia, ischemia, which are the most common causes of reversible cell injury. Apart from that, microbial agents, physical agents, toxins, drugs, free radicals, etc. Now, the morphologic form of reversible cell injuries are degeneration. Now, if the ischemia or hypoxia is of shorter duration, as I mentioned earlier, the effects may be reversible and the cell is restored to its normal state. Now, the basic mechanism of reversible cell injury, I'll just cover it in short as the details have been covered in your theory lecture. So, the first step is decreased generation of cellular ATP that leads to intracellular lactic acidosis and that causes nuclear clumping. Now, the next stage results in damage to plasma membrane pumps, that is the sodium-potassium pumps and the calcium pump. And the final stage is reduced protein synthesis. Now, withdrawal of acute stress that resulted in reversible cell injury can restore the cell's normal state, and as I've been mentioning this again and again, this is what differentiates it from irreversible cell injury, necrosis or apoptosis. Now, manifestations of reversible cell injuries are accumulation of normal substances in excess in cytoplasm or accumulation of abnormal substances in cytoplasm or intercellular spaces. Now, as I said, the degenerations are manifestations of reversible cell injury. So we'll be covering basically 4 kinds of degenerations here. One is hydropic change, fatty change, myxoid degeneration, and hyaline degeneration. So coming first to hydropic changes. So that's the earliest and commonest change of reversible cell injury. It is mild and reversible. Now, the basic mechanism behind hydropic change is failure of sodium-potassium pump, as we discussed, is the third stage wherein there is disruption of the plasma membrane pumps. So that leads to influx of sodium and accumulation of water within the cells. Now, if there is accumulation of small amount of water, it leads to cloudy swelling, and if large amount of water accumulates, it will lead to hydropic changes. Now, the organs affected are, most common is kidney, followed by liver, heart, and skeletal muscles. Now, the gross features of hydropic changes are as follows. The organ is enlarged, it is pale in color due to vascular compression, and it is soft in consistency. The cut surface will be bulging outward. Now, the microscopic changes are as follows. In cloudy swelling, the cell is swollen and shows eosinophilic granular cytoplasm. So the cytoplasm is granular. And in hydropic changes, there is ballooning of the cell, and there are clear cytoplasmic vacuoles and pale cytoplasm and nucleus. So basically there is empty looking cytoplasm. Now, this one is an example of a cloudy swelling wherein you can see the renal tubular cells have been showing swelling as well as granular amorphous deposits in the cytoplasm. Again, this is a high magnification image of a renal tubular cell, which is not normal. As we can see, the lumen is obliterated and the cells lining the tubular epithelium are enlarged, they are swollen, and the cytoplasm here is filled with eosinophilic granular material, which is commonly seen in cloudy swelling. That results when there is small amount of water deposition. Now, this is a classic example of hydropic change when there is large amount of water accumulation inside the cells. So this one is a normal renal tubule wherein there is an intact lumen. There are these lining tubular epithelial cells. The second image, as we saw the image earlier, shows cloudy swelling wherein the lumen is obliterated and the cells are swollen, showing eosinophilic granular deposits inside. Now compared to this one, in the hydropic changes, the cells, the lining epithelial cells will be still bigger, that there'll be ballooning of these cells, and there'll be multiple clear cytoplasmic vacuolations which might coalesce to form a single clear space inside the cytoplasm. The lumen is narrowed down just like in cloudy swelling. However, it is pale looking. So this one, the cloudy swelling, looks eosinophilic, that is pinkish, and the hydropic change looks clear, that is pale and light color. Okay, again, this is a hydropic change in kidney wherein we can see the tubular epithelial cells. They are distended with cytoplasmic vacuoles, and these are the interstitial vascular channels which show compression, which are the cause of pale look of hydropic change. The pale looking organ results from vascular compression, and the nuclei also are seen pale in the affected tubules and the lining cells. Another image, that's a magnification image of a kidney wherein we can clearly see that some of the tubules are showing hydropic change. For example, this one. So these tubules are showing hydropic change, while there are other normal looking tubules too. So these are the normal renal tubules which are not showing the hydropic change, and the interstitial vessels are compressed as we discussed earlier. Now in liver, there can also be hydropic change in the form of cloudy swelling, that is ballooning degeneration and feathery degeneration because of bile pigments. So here in liver cell hydropic changes, we generally see cloudy swelling wherein we can see granular pinkish eosinophilic material deposited in the cytoplasm of the hepatocytes, and we can see ballooning of some of the hepatocytes, as well as, not clearly seen here, but we can see bile pigment deposition, that is feathery degeneration. Now we were done with hydropic changes. Now we come to fatty changes. So the fatty changes, which is also known as steatosis, is the result of intracellular accumulation of neutral fat within parenchymal cells, that is fat metamorphosis. Now the pathogenesis behind this is depression of mitochondrial enzymes and defective lipid metabolism. So most commonly affected organ is liver, because liver plays a central role in fat metabolism. The most common cause is alcohol. Now other causes of fatty change can be diabetes mellitus, obesity, and starvation, and the other organs affected are kidney, heart, and skeletal muscles. Now in liver steatosis, grossly the liver is enlarged up to 3 to 6 kg of weight. It shows rounded borders, it's soft in consistency, and the cut surface is pale yellow and greasy. As you can see here, this is the normal liver. This is a specimen of fatty liver piece. In this case, the liver is enlarged, the margins are blunted and rounded, the cut surface looks bulging, and it is pale yellow in color, and the consistency looks soft, and also it looks slimy and greasy. So those are the gross changes in fatty liver. Now the microscopy shows vacuoles which are close to the nucleus, and they coalesce to form cleared spaces. So basically there is empty looking cytoplasm. However, the fat dissolves in paraffin embedding, and that's why the cytoplasm looks empty, as well as we can see peripherally pushed nuclei. So that's another gross image where we can clearly see the pale yellow color, greasy and slimy appearance, a little bulged out and swollen appearance, as well as uh, the blunting. Now the microscopic features, as I said, this one is a normal liver and this one is a hydropic fatty change in liver, wherein we can see these clear empty spaces in the cytoplasm which are formed due to coalescing of the small fat globules. Okay, so now initially the fatty change is microvesicular, wherein there are small fat globules. Later on they coalesce to form macrovesicular form, wherein there is a large clear space in the cytoplasm with a peripherally pushed nuclei. We can see a schematic diagram over here. This is the cytoplasm, a large big vacuole and peripherally pushed nuclei. Again here we can see some of the cells, hepatocytes, showing microvesicular changes, while some others show macrovesicular changes which results from coalescing of the microvesicles and also peripherally pushed flattened nuclei. Now the fatty change in cells can be detected by special stains, namely Sudan black B and oil red O. Here is a slide which shows the hepatocytes showing fat deposition, which is highlighted with oil red O stain over here. We can see the reddish, deposits, like a lot of reddish dots, small and big over here. Those are the fatty material stained by oil red O. Coming to myxoid degeneration, so we covered hydropic degeneration and fatty changes and hydropic changes. Now we'll come to myxoid degeneration. So basically myxoid degeneration results from mucin deposition. So mucin is a mucopolysaccharide and it literally means slime, and it is named like as mucin because of its slimy sticky character, and normally it is secreted by epithelial cells of mucous membranes and mucous glands. So myxoid degeneration is basically excessive collection of this mucin, whether intracellular, extracellular or both. Now epithelial mucoid degeneration results from acute inflammation of mucous membranes or epithelial tumors, for example bronchi, GI, ovary, gallbladder. It also results from malignant epithelial tumors of breast. Another form is connective tissue or mesenchymal mucoid degeneration, which is also known as myxomatous degeneration, that results from cardiac ischemia seen in heart valves, fibroadenoma breast, also seen in benign malignant salivary gland tumors or soft tissue tumors, myxomas, sarcomas, etc. So basically connective tissue myxomatous degeneration is seen in lesions of mesenchymal origin. Now grossly, mucin is a slimy gelatinous material, and the cut surface of the organs usually shows cystic changes filled with sticky slimy gelatinous material, and the cut surface appears shiny and gelatinous. So here we can see these are the cysts which are filled with slimy gelatinous sticky material. Now practical demonstration of sticky character of mucin, wherein when we touch take it in the between the thumb and the finger and then try to separate the thumb and the finger, there will be formation of this thread like sticky material. Again, this is a gross image of an organ showing a tumor basically showing myxoid degeneration. You can here you can see these cystic spaces filled with gelatinous material here. Now microscopically, how do we recognize mucin in H&E stain? So mucin is structureless, basophilic in appearance. So the organ with myxoid degeneration will appear, the area will appear more bluish compared to the rest of the area. Now there are also droplets in cytoplasm which coalesce, and basically the mucin ruptures out. So epithelial, there are again, as I said, two kinds of mucin degeneration. One is epithelial, another is mesenchymal. So in case of epithelial mucin deposition, there will be large pools of light blue colored mucinous material, and the epithelial cells will be floating in those pools. Whereas in mesenchymal mucinous degeneration, there will be light blue colored myxomatous material in which spindly stromal cells are embedded. So basically, the material separates the spindle cells. Here, this is a slide, classic slide showing myxoid degeneration, which is epithelial in nature. We can see mucin pools here and there. Almost in all the glands, we can see mucin pools, and these are the floating cells. So basically, this is a mucinous carcinoma of breast, and we can see tumor cells floating in mucin. Again, myxoid degeneration, which is epithelial in nature. So here we can see mucinous pools and floating cells. Now, in this case, this is a slide of pleomorphic adenoma of the salivary gland, wherein we can see these are the ductal cells, these are the myoepithelial cells, and this area, which is structureless, is basically mucin deposition, which is mesenchymal mucin deposition. Again, here the left area is cellular, composed mainly of myoepithelial as well as glandular cells, and the right area, which is basophilic and appears more bluish compared to the other areas. So this is the myxoid stroma, which is the mesenchymal myxomatous degeneration. Again, this is an example of mesenchymal myxomatous degeneration, wherein we can see this area, which is pinkish and cellular, and this area, which is hypocellular, structureless, and consists of large amounts of mucin with sparse cells separated with the mucin. Again, here this was an anterior cruciate ligament slide. Again, this is an anterior cruciate ligament or a tendon, wherein we can see these fibers these are the normal fibers which appear pink, and they are the muscle fibers, and these normal muscle fibers are separated by some of the muscle fibers which have undergone reversible cell injury, and which is manifested as myxoid degeneration. So here we can see these fibers are more basophilic and bluish in appearance compared to the normal fibers. They are separating these normal muscle bundles. So again, myxoid ground substance, this is a myxoid ground substance which is blue-gray in color and separates the normal collagen bundles. Now, this is a myxoid degeneration which is seen in heart valve. So this is a heart valve, and these are the normal fibers of the heart valve, and so it shows pinkish. It is pinkish and cellular. However, these areas are showing myxoid degeneration, that is myxomatous degeneration, and so they are sparsely cellular, and here the muscle fibers are separated by mucinous material, which is which is seen like clear substance, a structureless clear substance. Now, for what are the special stains? So basically, the special stains for mucin are PAS, that is periodic acid skiff, alcin blue, and mucicarmine. Here, the right side, this image shows mucin, which is highlighted with mucicarmine stain. Yeah, this pinkish red material is seen here and there, that is the mucin. Coming to hyaline degeneration. So hyaline degeneration can be intracellular or extracellular, and both epithelial and connective tissue can be involved. What does it represent? It basically represents end-stage lesion. Microscopically, hyaline is structureless, homogeneous, and it is a glassy pink material. So basically, hydropic change shows water accumulation, which is seen as either eosinophilic material or clear cytoplasmic vacuoles. Next comes fatty change. Fatty change is seen as a small and large vacuoles in the cytoplasm of cells and clear empty looking spaces. And how can we differentiate? Hydropic change has water, and the fatty change has fat cells which are highlighted with special stains like oil red O or Sudan black P. Next was myxoid degeneration. So myxoid degeneration, how do we identify it? Basically, the area with myxoid degeneration will look more bluish compared to the rest normal pinkish area. Here in hyaline degeneration, the affected area looks homogeneous as well as pinkish. Sites commonly affected by hyaline degeneration are in epithelial sites, it is liver cells, tubular epithelium of kidney, and prostate corpora amylasia is an example of hyaline degeneration. Now, in connective tissue, the hyaline changes are seen in Zenker's degeneration of muscles, connective tissue tumors, arteries, that is arteriosclerosis, and in long-standing scar. So this is classic image of hyaline degeneration, wherein we can see the entire tissue area has been converted into a homogeneous, glassy, pinkish looking material, that is hyaline. This is a classic image of hyaline degeneration of arteries, that is arteriosclerosis. We can see the thickening of the arteries as well as the obliteration of lumen and glassy, homogeneous, structureless pink material deposited in the media. This is the hyaline degeneration of prostate, and these structures which we see here in the lumen of the glands are classic of BPH, that is benign prostatic hyperplasia. We call them corpora amylasia. So this corpora amylasia, these are the structures which show laminated hyaline, and they are basically manifestations of hyaline degeneration of prostate. Now next, coming to calcification. So calcification is also known as calcareous degeneration or pathological calcification, which is abnormal deposition of calcium salts in the cells. Now calcification can be of two types. One is metastatic calcification and another is dystrophic calcification. Now metastatic calcification occurs in hypercalcemic states, and it is basically reversible. The common sites are arteries, gastric mucosa, lungs, and kidneys, and basically it results from two conditions: either excessive absorption or excessive mobilization of calcium from bone. Now dystrophic calcification occurs in dead or dying cell. That means it is irreversible kind of calcification, and in that case the serum calcium level is usually normal. So basically the dystrophic calcification is a result of defective calcium channels which leads to calcium deposition in the cells. Now dystrophic calcification can be seen, as we discussed, in dead tissue as well as degenerated tissue, that is dead cells or dying cells. So dystrophic calcification in dead tissue, the examples are all the necrosis, for example caseous liquefactive coagulative necrosis, and the organs are TB involved lung or lymph node. Samoma bodies seen in papillary carcinoma are also example of dystrophic calcification. Necrotic foci of tumors can also show dystrophic calcification. Fat necrosis, infarcts, hematomas can also show dystrophic calcification. Thrombi can also show dystrophic calcification, wherein it is called as phleboliths. Dead parasites like cystosoma eggs can also show dystrophic calcification. So now dystrophic calcification in degenerated tissue can be quoted as, the examples are scars, dense scars, atheroma, that is atherosclerotic patch can show calcification inside the patch. Calcinosis cutis is again a condition of usually affecting scrotum, which also shows dystrophic calcification, and age-related degenerative changes can also result in calcification. Now coming to metastatic calcification, the two main causes are excessive absorption of calcium from gut, that is basically caused by hypervitaminosis D or hypercalcemia of infancy. And the second cause is excessive mobilization of calcium from bone, which results from either hyperparathyroidism or bone space occupying lesion like malignant or multiple myeloma, metastatic carcinoma, which causes lytic lesions in bone, which results in mobilization of calcium from bone into the bloodstream. And the third cause is prolonged immobilization, which also results in bone lysis, osteolysis, and the calcium from the bone goes into the bloodstream, leading to hypercalcemia. Now, grossly, the calcified patches show hard and chalky white appearance, and the tissue is gritty to cut and cuts with difficulty. So basically, it looks hard and chalky white. Yeah, here this is the gross image wherein we can see this lesion, well-defined, well-circumscribed lesion inside an organ, wherein these are the patches of calcification. We can see your white chalky deposits. They are the calcification patches. Now, microscopically, calcification or calcium deposits are seen as amorphous basophilic granules or small clumps. Now, the calcium salts, they deposit in laminated manner. So that is that classic presentation known as Samoma bodies, which is seen in papillary carcinoma, thyroid, and meningioma. So yes, this is an example of Samoma body. This is a papillary carcinoma showing Samoma body. This one is an atherosclerotic patch which shows calcium deposition, amorphous bluish granular material, and here it is laminated material. Yeah, so this is an example of calcium deposition, that is degeneration, calcareous degeneration in dead tissue. And this one is calcareous degeneration in degenerated tissue or dying tissue. Okay, again, this is calcium deposition, that is calcification, pathological calcification, showing basophilic amorphous deposits. Now coming to pigments. Now there are three kinds of pigments: endogenous, exogenous, and artifactual pigments, which are basically not related to the pathology, basic pathology. Now, endogenous pigments can be hematogenous, non-hematogenous, and minerals. Basically, for us, what is important is some of the hematogenous pigments like hemosiderin, bile pigments, and non-hematogenous pigments which are important are melanin and lipofuscin. So coming to lipofuscin or lipochrome, basically it is a breakdown product which results from oxidation of lipids and lipoproteins, which is also known as a wear and tear pigment. It is yellowish brown in color when seen in microscope. The most common organs which are affected or which show lipofuscin pigments are heart, liver, also CNS and adrenal cortex. Again, the special stain is Sudan black B because it contains lipid, and it may also exhibit a strong orange autofluorescence in formalin fixed unstained paraffin section, which before staining are directly focused on a microscope. Here, so the gross specimen with the lipofuscin pigment deposition will show yellow-brown discoloration. Microscopically, we can see coarse golden brown granules which are deposited surrounding the nuclei, that is perinuclear deposition of golden brown granular pigments. So these are the granular golden brown pigments which are the lipofuscin pigment in the cardiac muscle fiber. So basically it is a wear and tear pigment showing wear and tear of the heart muscles. Here, this is the H&E section of a liver which shows hepatocytes, and hepatocytes are showing these golden brown pigment deposition, which is nothing but lipofuscin. Coming to melanin. Now, melanin pigment is microscopically brown to black in color when stained with HNE. It is normally present in skin, adrenals, pyometer of meninges, and choroid of the eye. Special stain is Masson Fontana. Now, increased deposition is seen in nevus malignant melanoma, and it is absent in albinism, decreased in leprosy. So now this is a hygiene section of skin wherein we can see this epidermis, and epidermis has these basal cells which consist of melanocytes. These melanocytes produce melanin. They are seen having these brown black pigments, and also the superficial layers of epidermis can also have these pigments, melanin pigments inside the cells, which are basically phagocytic cells called melanophores. Again, this is a cut surface of a skin specimen, and these are the basal cells showing thick deposition of melanin pigment. They are the melanocytes, and these are the melanophores. And that's the superficial layer, stratified squamous epithelium. Coming to hemosiderin pigment, that is blood derived pigment. It is golden yellow in color, golden yellow to brown in color. It is derived from hemoglobin breakdown, so contains iron, and that's why it is stained with Prussian blue or pearl stain. Basically seen in two situations. One is excessive destruction of RBCs, and that is because of basically acquired cause. That is example, multiple transfusions in diseases like sickle cell, thal, sideroblastic anemia. And the second cause is systemic overload due to primary cause, that is a metabolic cause, and that is known as primary hemochromatosis. You must have heard that term. Now, normally, hemosiderin is normally seen physiologically in macrophages of the reticuloendothelial system, that is bone marrow, liver, and spleen. However, its excess deposition results from either primary cause, that is hemochromatosis, or acquired cause, that is multiple transfusion or increased breakdown. And this is classic slide showing primary hemochromatosis of liver. Here you can see the hepatocytes, and all of them are showing hemosiderin, golden brown pigment deposition, and all these are basically stained with, because they contain iron, they are stained. Have to confirm whether it is a hemosiderin pigment or it is a lipofuscin pigment. How do we confirm? We confirm it with pearl stain or Prussian blue stain. So lipofuscin will be stained with Sudan black, and hemosiderin will be stained with pearl stain, and it will show a blue color. So yes, these are the blue granules, which are the hemosiderin granules stained classically by pearl stain. Now the exogenous pigments are, the examples are tattoo, carbon, leading to condition called anthracosis, silicosis, asbestosis, etc. So this is a slide, HNE section from respiratory tract, which shows deposition of inhaled carbon, which is known as anthracosis, which is the most common cause of pigment deposition in lungs. Again, this is an example of anthracosis. Okay, so this is a silica crystal. This is an asbestos crystal which highly resembles silica crystal, and over the period of time there is deposition of calcium iron protein complex over these crystals, which leads to its positivity when stained with Prussian blue or pearl stain. So asbestosis can be diagnosed later on with Prussian blue pearl stain, as it contains iron coating over it. And the crystals are needle-like crystals, needle-like, silica-like crystals. Now, artifactual pigments are those which are actually not a part of pathological changes of the organ. So basically, the examples are, basically artifactual pigments are a part of either processing or some exogenous some non-related condition. For example, formalin malarial pigments, mercury, or chromium oxide. Thank you.